I'm not going to talk very much yet. I'm just going to introduce Jerad. Jerad is absolutely amazing because, as many of you guys have noticed that have already asked me questions about how this program works, there's not a lot of information available. And Jerad is the reason I know so much about it, because he actually took the time several different times now and has gone through the program with me. You're not going to find very many people that will do that. So I'm just going to shut up and let you talk, Jerad.
All right. First off, I'm going to do a mic check. Can you all hear me okay? Okay, cool. Because my computer restarted and that just sort of shifts all of my settings around sometimes. So let me see if I can get the PowerPoint up here. Everybody seeing it okay?
Yep, you're good to go.
Cool. And you're probably seeing the wrong view of this now. So let me see if I can correct that. Come on now. We'll get there. I apologize. Oh, is it? Which view is it showing right now? Are you seeing the full screen or are you seeing my desktop?
I'm seeing your desktop. It may be that the slideshow view is in a different.
It is. It's in a different window here. Let me.
So hit share screen, and then find the one that has the actual slideshow in it, and then you should be good.
Yeah, I'm just going to share my whole desktop here, and that's still happening.
There we go. You're perfect.
Oh, you can see it?
Yep.
Cool. All right. So as Tabitha said, my name is Jerad Bailey. I'm the Director of Pharmacy Operations for Cabin Creek Health Systems in Kanawha County, West Virginia. Our main office is actually located in Charleston, West Virginia. So full disclaimer, you may hear me talk about West Virginia a lot, and that's because I'm just sort of programmed to do that. So if I talk about West Virginia Medicaid, it's probably going to apply to every other Medicaid program as well. So just keep that in mind. Some of the stuff should not be specific to West Virginia. It's just a habit that I have. Now, a disclaimer or a few disclaimers about this presentation. This is an adaptation of an annual lecture I give to the University of Charleston School of Pharmacy. So this used to be a lecture for their second year students. Then they changed their curriculum to where it was a first year program. And this is an adaptation of that because I know that what you are going to be interested in is perhaps less so than what pharmacy students are going to be interested in. So I'm trying to tailor it a little bit more to that. And also, while 340B is very important, this is really inside baseball stuff. Okay. So if you have any questions, I would highly encourage you to ask them. I know there's the Q&A function. I know Tabitha and Amanda will be monitoring that, but this is... There's a lot of nuances to this program. I want to help you understand them. So please feel free to ask questions. So what is the 340B program? So the 340B program enables covered entities to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. Now, you will notice that throughout this presentation, I'm going to be highlighting the word covered entities very frequently because it comes up a lot, and it's important to know this particular definition. So we'll talk about what covered entities are, but these are typically the clinics or the hospitals, not the pharmacies. Okay, so when you see covered entity, we're talking about a facility that is providing healthcare to the patient. In the second bubble, manufacturers participating in Medicaid agree to provide outpatient drugs to covered entities at significantly reduced prices. So the government said, if you want to play ball with Medicare and Medicaid, you've got to provide better prices to these covered entities. And last, eligible healthcare organizations / covered entities are defined in statute and include a big list of things that I'm going to share a little bit later. It goes way further than what this particular bubble does. So let's get down into the history. So the 340B program, to talk about the genesis of the 340B program, we have to talk about the Medicaid rebate program first. And this was passed in 1990. And the government pretty much said that any drug manufacturer that wants their medications to be covered by Medicaid or Part B is required to enter into a rebate agreement with the Department of Health and Human Services. which states that the manufacturer agrees to pay rebates to the state Medicaid programs for covered outpatient drugs based in part by the manufacturer's best price for that drug. What that means is that Medicaid always pays the lowest price available for a covered outpatient drug, and Medicaid gets a rebate afterwards. So if anyone recalls buying a cell phone back in the early 2000s, and you'd get this cell phone and you do a mail-in rebate for like $200 for your cell phone, that's kind of what's happening with Medicaid. Medicaid pays full price for the drug, then they get reimbursed by the manufacturer what the difference is between what they paid and the cheapest price available. So 2 years later was the creation of the Veterans Healthcare Act of 1992. This was created under Section 602. So this requires drug manufacturers to enter into a pharmaceutical pricing agreement with covered entities. And this pharmaceutical pricing agreement was essentially the same price points as the Medicaid agreement. So they're pretty much getting the same exact pricing. The big difference is that manufacturers are required to provide the rebated cost of the medications on the front end. So if you recall getting that cell phone in the early 2000s, and maybe you went to Radio Shack and they said, there's a $200 mail-in rebate. We'll give you that $200 off right now if you buy in store, and you don't have to worry about mailing in or anything like that. So that's what happens there. So where West Virginia Medicaid kind of waited for a rebate check from the manufacturer, covered entities get the cheap price off from the get-go. So it is important to note that the covered entity is going to be the one receiving these monetary benefits. It's not going to be the pharmacy that's dispensing these drugs. And we'll get into how that works a little bit later. So here's a full list of what covered entities covers, actually. So number 2 on that list, federally qualified health center. That's actually what my organization is, a group of federally qualified health centers. But we have a lot of indigenous peoples, Ryan White, hospitals, STD clinics, a lot of different programs that are actually covered in this 340B covered entity bubble. So it's a lot of places that are actually can actually be part of this. So I've talked about covered entities. Let's talk about contract pharmacies, because you invited me on because I'm a PharmD and we talk about drugs, and I haven't talked much about pharmacies yet. So excuse me, any pharmacy being used by a covered entity in lieu of or in addition to an in-house pharmacy can be a contract pharmacy. So my clinics could enter into a voluntary contract with an outside pharmacy and benefit from their services. So, we would be able to provide our patients extended pharmaceutical care, and the contract pharmacy would receive some benefit that would be determined in the contract. Now, these are voluntarily selected by the covered entity. So, a chain like Walmart can't just knock on the door and say, hey, we've got your patients covered. No, that's not how it works. This is it's voluntarily selected by the covered entity, and a contract has to be drafted up before any type of arrangements can be made. Now, contract pharmacies do require oversight from the covered entity, because Hersa, who handles the 340B program, has stated that pretty much the entire onus of compliance is going to fall on the covered entity. There's also something called a third-party administrator. So a third-party administrator, or TPA, is an organization which assists with the creation and maintenance of covered entity and contract pharmacy partnerships. So some of these can get pretty complex. Now, it's not required to use a third-party administrator, but a covered entity absolutely can, just to help them with the operation, because some of the contract rules and stuff with some of the larger pharmacies can get a little bit complex. There's some claims that they want to be eligible, some they don't want to be eligible, and a TPA can help with that. Now, the most common TPA I know of is Capture RX. I'm not sure if anyone in here has heard about them, but they are one of the larger third-party administrators assisting with 340B covered entities. So third-party administrator is helpful in that they can actually handle program setup from the ground up. They can handle contract negotiations. They can filter eligible claims, help with product ordering, financials, and self audits. And a TPA can really make a covered entity's job easier, but it doesn't remove all the workload because, again, at the end of the day, the covered entity is responsible for compliance for all 340B laws and rules. So setting up and maintaining yourself on the 340B program. Every year, a covered entity and contract pharmacies have to renew their agreement. So this happens annually. It happens, and it's not like an automatic, like you have to opt in every single year. So for example, where I work, our contracts renew every April. So in February, I had to go through the process of getting all of our facilities recertified. So if you want to start a new program, Hersa only handles new applications on a quarterly basis. So January, April, July, and October. And you have 2 weeks to get your application in. So if you are hoping to get your program started in April, that means that you have to begin the process in January for you to even be able to receive 340B benefits in April. Amanda, did you have something or?
Yeah, so so one of the questions is so the TPA acts as the PBM for the 340B, is that right?
They're not really a PBM because they're not really, they're sort of a go-between. Really what they're doing is they're trying to pick out claims that are 340B eligible, and we'll talk about eligibility requirements in a moment, but they aren't really responsible for like formularies or reimbursement or anything like that. The insurance is still involved in that process. The TPA should just be like picking out claims and stuff like that. So I wouldn't really call them a PBM in this particular case. Hopefully it clarifies a little bit later in the presentation. If not, we can kind of re-examine that.
Okay.
But
so Jen, stay tuned. Looks like a little bit further into the presentation, we'll go ahead and we'll be able to answer that a little bit more clearly. Thanks.
hopefully, and if not, we can pin that down a little bit more.
Okay.
So if you are re-registering for the 340B program, that happens a few months after like initial registration. So like I said, for April, if you were hoping to be registered in April, you had to start the process in January. If you're hoping to re-register in April, we started that process in February. And again, we have to make sure we do that. There's a limited window to do it because let's say, for example, we did not re-register our pharmacies or our clinics for April. We would have to register as a brand new facility. And from April to July, we wouldn't have access to 340B medications. So that could be a pretty big deal if you don't make those registration windows. So the 340B drug pricing program points to like eligible patients. Like that they'll use the verbiage eligible patient or covered patient frequently. And to determine what an eligible patient is, basically we've got about 5 little paragraphs here that sort of go into this. And I'm going to break these down a little bit. So the first bullet here is to be eligible to receive 340B purchased drugs, patients must receive healthcare services other than drugs from the 340B entity. An individual is a patient of the 340B covered entity only if. So number 1 states that the covered entity has established a relationship with the individual such that the covered entity maintains records of the individual's healthcare. So back when I was in pharmacy school, one of the big buzzwords was medical home. And that's kind of what they're getting at right here is the Hersa wants this patient to establish a medical home. And this is a place that might take care of, might handle their primary care, but also any records from any other facilities. This is kind of the clearinghouse for like all this patient's medical information. They want to know that the patient has established care there and that they maintain their care there. And that's requirement number 1. Requirement number 2 has a few more pieces. So first, they want to make sure that the individual receives healthcare services that go beyond just receiving medication. Just receiving a drug doesn't make you a patient. From a healthcare professional who is either employed by the covered entity, and there's nuances to this. So first, the healthcare professional works at the covered entity, and they are acting on behalf of the covered entity at the time. So let's say you see Dr. Smith, who works Monday through Friday at your clinic, but on Saturday and Sunday, they help out at MedExpress. And you've been seeing Dr. Smith for a good long while, and you go see them at MedExpress. And technically those prescriptions, you wouldn't be considered an eligible patient because you did not see Dr. Smith at the covered entity. Then the last major bullet, or provides healthcare under contractual or other arrangements, such as a referral for consultation, such that the responsibility for care provided remains with the covered entity. So let's say you see Dr. Smith and they check your A1C and your A1C is 14, and Dr. Smith says, I don't know what to do with you. I'm sending you to an endocrinologist. Because you are referred to an endocrinologist and it was determined that was the absolute best care for you, you can still get those prescriptions from the endocrinologist because we are still covering your health. We didn't pass you off completely. Just this particular part of your health, we're having a specialist look into. So that is where you can refer. So patients can be referred out to specialists and still be 340B eligible. The referrals have to be facilitated by the covered entity though. So if you have a bad case of acne and decide to self-refer to a dermatologist, that doesn't count. If it is Saturday and you have a stomach bug and you need to go to MedExpress, those prescriptions don't count. If you wake up in the middle of the night with chest pain and go to the ER, those prescriptions don't count because they are considered self-referrals. And last, the important thing is that in all these cases, the covered entity is still maintaining control of the patient's records. They're still the medical home. Now, requirement number 3, the individual receives a healthcare service or range of services from the covered entity, which is consistent with the service or range of services within the scope of practice. So if the covered entity provides that service normally, you're good to go. So if you are, so our facilities actually have dentists. So we have dental offices there. If you were to go to the dentist and they wrote you something for, I don't know, athlete's foot, something that's completely detached from, oral facial, that's not within their scope of practice. Now at the clinic, there's absolutely someone that could probably write you something for athlete's foot, but it's not within the scope of practice of that provider. So it has to be something that is within scope. And this is one of the easier rules to actually follow because I don't think many facilities are doing too much stuff outside of their scope. So a little flow sheet to determine if a prescription qualifies for a 340B discount. Does the patient use the covered entity's facility? Does the covered entity maintain their medical records? Did you receive care from one of the covered entity's providers? And if not, were you referred? Did you receive a service that the covered entity is allowed to offer? And if you can answer yes to all of these, you can fill these as a 340B benefit. So in the 1992 Congressional Report on the purpose of the 340B program, one of the more poignant quotes that came out of this is the 340B program is to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. So how does it do that? Well, let's take a look at basic flow of the pharmacy. So this flow sheet will get a little bit more simple as we go on. But if you go from left to right, we're basically tracking a medication from the time it's made to the time it gets to the patient. Now, as we go to the right, we're following our medication supply. And as we go to the left, we're following cash flow. So the patient pays for the medication, the pharmacy pays the wholesaler to replenish, and the wholesaler pays the drug manufacturer to keep it in stock. So this is our general flow that we're going to start with. It's the backbone of everything that has to do with pharmacy. So step 1 is the wholesaler purchases medications directly from the manufacturer. Next step is that the pharmacy purchases those medications from the wholesaler. And then the patient purchases the prescription from the pharmacy. That's our flow. Now, to talk about 340B, we kind of have to talk about Medicaid. I was about to say West Virginia Medicaid, but this is all Medicaids. Medicaid is going to interrupt this basic flow at several points. So first of all, Medicaid's establishing relationships with patients. And Medicaid says, okay, we're going to reduce the cost of your prescription drugs and help you out with your medical costs. That's the relationship we've created. Now, when a patient goes to the pharmacy with Medicaid and they purchase prescription, Medicaid is going to reimburse that pharmacy. So the patient isn't paying the entirety of that copayment. Medicaid is paying the vast majority of it, from 70 to 100% in West Virginia. Your mileage may vary depending on what state you're in. So Medicaid reimburses the pharmacy for that prescription. And then Medicaid, through the 1990 agreement, receives a rebate from the drug manufacturer based off of the best possible price. So we've created a few loops in here. Medicaid has integrated itself into this flow here. Now, 340B works kind of similar. So we're talking about the same prices and stuff. So the covered entity registers with Hersa's Office of Pharmacy Affairs, which enables them to receive medications at the 340B price. Next, when the covered entity sets up an account with the wholesaler, it's set up as a 340B account. So not only do we have modifying the relationship between the wholesaler and the covered entity, but you're modifying the relationship between the wholesaler and the drug manufacturer, because the drug manufacturer is the one now selling these medications to the wholesaler for the cheaper price. It happens virtually, and again, that's kind of inside baseball, the way that works, and we can go into it a little bit, but just know that this relationship sort of modifies the prices on this end. So the covered entity has to establish a relationship with the patient, so the patient becomes a covered patient and now eligible for 340B drugs. The covered entity creates a relationship with an outside pharmacy. So now there is a contract pharmacy that the covered entity is working with. Now, the way this works is that once you have a contract pharmacy and the covered entity has a relationship with the wholesaler, the covered entity, so like the health center, is actually the one being billed for medications. So you'll notice in this image, the contract pharmacy is no longer buying these medications. The clinic, the covered entity, is buying the medications. The medications are being shipped to the contract pharmacy. Then what happens is when the covered entity goes to that pharmacy to get their medications, the profits from that transaction aren't going to the contract pharmacy, they're going to the covered entity. Now, there's going to be terms and conditions in the contract that dictate how much the contract pharmacy gets from each transaction, but this is how this works. So the covered entity is buying these drugs for much cheaper, and then by extension, they are receiving the profits from the patient and the insurance instead of the contract pharmacy. So this is kind of your final product here. And you'll notice that the contract pharmacy isn't really handling that much money. That money flow isn't going through the contract pharmacy. It's actually bypassing completely, going from the covered patient to the covered entity to the wholesaler at this point. So what's this look like if we have a in-house pharmacy? So my clinics have 4 in-house pharmacies that are owned by the covered entity. And a covered entity can opt to do that. So they can use in-house pharmacies, they can use contract pharmacies, they can do both. They can use a combination if they so desire. So let's say, for example, our covered entity now has an in-house pharmacy. What does that look like? Well, we're pretty much Xing out everything that has to do with that contract pharmacy. We've been paying for the medications. Now we are receiving the medications. Now we are also dispensing the medications and we're receiving all that money. So we've kind of cut the middleman as far as the contract pharmacy out. So you'll see that there's absolutely no flow making it to that contract pharmacy, which means, you know, you don't necessarily need that bit in this particular case. So let's do a case study. So let's say we have a patient who has a well-known third-party payer insurance. You can insert whatever your favorite one is here. It does not matter which one. So this patient plan says that they have a flat copayment of $5 for generic drugs, $15 for preferred brand, and 20% of the medication cost for a non-preferred brand medication. Now, this patient sees a provider at a facility designated as a 340B covered entity, and for all intents and purposes, they're a covered patient. So we don't need to worry about patient definition and all that stuff. Not trying to trip you up here. Now, Dr. Smith has written this patient a prescription for rosuvastatin 20 milligrams, 1 tablet by mouth daily, dispense 30 with 5 additional refills. Now, the patient has the option of using one of 3 pharmacies. So let's say they can go to just a regular pharmacy. They can go to, you know, we'll say Walgreens. They can go to a 340B contract pharmacy. So let's say Kroger has contracted with this location to offer, you know, contract pharmacy services, or they can use the facility's in-house pharmacy. Now, it's important to note that the law says the patient is free to use whatever pharmacy they want. So even though your clinic has a pharmacy, there's nothing that says that the patient has to use that pharmacy. They are free to go wherever they want. And that is something that we can kind of look into a little bit more. So let's say the patient's insurance reimburses pharmacies based on the medication's average wholesaler price, plus a dispensing fee of $10. So the average wholesaler price, to put it bluntly, is a made up number. I don't know where it comes from, where its origin is, but it is loosely based off of the actual acquisition of the drug, and a lot of places use it for their pricing structures. So I don't think there's really a method or formula or anything to determine what the AWP for a drug is. It just kind of exists as some sort of price point that you can use. Now, this rosuvastatin 20 has an AWP of about $9 per tablet. It's pretty pricey. Now, most major chain pharmacies can purchase rosuvastatin 20 milligrams at $7 per tablet. So Kroger, when they buy it, it's going to be $7. When CVS buys it, or sorry, Walgreens, that was my example, Walgreens, when they buy it, it's going to be $7 a tablet. But the 340B best price for rosuvastatin 20 milligrams is 3 cents per tablet. Pretty stark difference between, you know, the purchase price for this medication. So question 1, how much will the patient pay at each pharmacy? This one is kind of a trick question because we already determined that because of their insurance, they've got a flat copayment of $5 for generics, 15 for brand, and 20% for non-preferred brand. Rosuvastatin is the generic for Crestor. So regardless of where this patient goes, they're going to pay $5. And they're going to be none the wiser as to how like the 340B stuff works. They're just going to pay $5. They're going to get their drug. They're going to go on their way. Now, the pharmacy part is where it gets a little more challenging. How much will each pharmacy or clinic be reimbursed if they fill the rosuvastatin 20 prescription for this patient? So if we look at our Walgreens example, who has no relationship with our health center at all, rosuvastatin costs them $7 a pill to even get into the pharmacy. So times 30 tablets, it's going to cost them $210 to get this bottle in. Now, the insurance is going to reimburse them based off AWP, which is $9 a tablet or $270, plus a dispensing fee of $10. So if we do the math here, the 270 plus 10 minus the 210 it cost us to even get in the door, this pharmacy makes $70. 5 of it's going to be from the patient's copayment, and the other 65 will be mailed from the insurance to the company. So what if that patient goes to Kroger? Well, patient pays $5. We already discovered that. But what's the cash flow look like now? So as we said earlier, in this covered entity contract pharmacy relationship, the covered entity is the one purchasing the drugs. And the covered entity can buy this rosuvastatin 20 for 90 cents, which is a far cry from $210. The best thing about this is that the insurance is still reimbursing based off of the AWP, which in this case is $270, plus the $10 dispensing fee. So you've got $280 that the insurance is going to reimburse you, minus the $5 copayment that the patient is already paying, minus the 90 cents that you paid for the drug. The covered entity is actually going to make $274 off of this prescription. And the $5 from the copayment that the patient paid to get the drug is going to go to the contract pharmacy. And really any difference between those numbers is going to be based off the contract. So, even if they split 50-50, for example, let's say they split things 50-50, this was about $280, we'll call it. If Kroger makes 140 and our clinic makes 140, I mean, that's better than just the 70, right? Like everyone benefits from, even if it were like a 50-50 deal, everyone benefits. Now it's not going to be a 50-50 deal. It's going to depend on the pharmacies and, TPA agreements and all that stuff. Again, that's been inside baseball. But this can be mutually beneficial for both organizations to have this agreement. Now, what if we cut out that contract pharmacy completely? So, 30 tablets still cost the clinic 90 cents. We're still getting $280 in total. So the covered entity makes $279 in profit. So you without any type of agreement. So you don't have to split it 50-50 or anything like that. You just made $279 profit off of a single Crestor prescription, basically. And again, patient only paid $5 for each of these. So to answer our questions, how much will the patient pay at each pharmacy? $5. Now, if the patient is none the wiser as to how 340B works, what might drive their decision to use any of these pharmacies? Well, Walgreens has extended hours of access. So you might be able to go to Walmart 24/7, 365. So if you've got a weird schedule, maybe Walmart's attractive to you, or, there's a lot of Walgreens. Maybe there's one next door to your house or close by. So it's just convenient to be able to drive to it. Kroger has groceries, so like you can go do your grocery shopping and then pick your prescriptions up at the end there. Or what about the clinic? Well, I go see the doctor pretty regularly anyway. And by the time I get out of the doctor office, they've got my prescription ready for me and I just cut a trip out of my busy day. So there's benefits to either one of them. So it could be access, distance, any of those things that, the same reason you try to fight with yourself as to which grocery store to go to this week. And, whether or not you can go to this grocery store instead, or do you have to go all the way out here to get this certain thing? And then the table down below just kind of breaks down what that reimbursement looked like at each of the pharmacies. So as a covered entity, scenario 3 is going to be your most lucrative, in which case you don't use any contract pharmacies. That said, that might not be in the cards or an available option to you. Scenario 2 is where you are using contract pharmacies, and those numbers can vary. So if you can just imagine a slider going between $5 and $274, it ends up being mutually beneficial, or at least you can come to some agreement where it's mutually beneficial for that pharmacy to enter into that agreement with you. So we're going to take a second case study here, and we're going to talk about a patient that has no insurance and has to pay out of pocket for medications. Now, this doesn't necessarily mean just patients with no insurance. This could be your patients that are underinsured as well. So patients who have coverage, but their insulin costs $80 because that it's a brand medication. That's what the formulary says it's going to be. So this is still relevant to this group because you may have patients that are underinsured. Amanda, did you have something?
So you're gonna laugh at me, but I have to ask, what does inside baseball mean? Because I don't do sports and I have no clue of what you're talking about.
We're talking like real gritty details, like how the sausage is made, like just really granular stuff. Like
Okay,
it's
well, that I can get. So
yeah,
okay.
yeah. So that's what I'm getting at there. So yeah, some of the stuff I'm talking about when I say that it's really granular, we're really, getting pedantic
You're in the
about
weeds.
details.
That's a
Yeah. Like this is the geeky stuff that me and some other 340B aficionados might talk about. But
it's the fine print. So I do that with like Medicare guidelines and the nuances with insulin savings model and that type of stuff. So okay,
Yeah.
that makes sense.
Okay.
Thanks.
Thank you for asking that. I don't want you to be lost at any point here. So case study 2, we have our uninsured or underinsured patient that has to pay out of pocket. Patient is still an eligible patient. They see a provider at a 340B covered entity. Dr. Smith writes that same prescription, rosuvastatin 20, 1 tablet by mouth daily, dispense 35 refills. And to simplify this further, the patient has 2 options. They can either go to a regular pharmacy or they can use the covered entity's in-house pharmacy. And what is the patient's best option? You can probably anticipate what the answer is going to be. So most pharmacies, when they come up with a cash price, it's based off of the acquisition cost of the drug. That's a good starting point because you don't want to undersell yourself. Like, if it costs me $5 to get the drug in the door, I'm at least going to have the price be $5. Otherwise I lose money. So usually this acquisition cost is given a markup. So in our example, we're going to mark up this amount by 20%. So if it's a bottle that's $5, marking it up 20% means that there's another $1 added to that. So we're up to $6. And then we're going to add a dispensing fee. And this is just kind of a flat fee for, services rendered. So the dispensing fee is kind of like what pays your payroll, what keeps the lights on, that type of thing, and is based off of the actual volume of prescriptions you're doing, not necessarily what you're filling. So let's assume that every pharmacy ever uses acquisition as what they're basing the cash price off of, mark it up by 20%, and then add a $5 dispensing fee. So if we go to that Walgreens, that it costs $7 a tablet for them to get that medication in, and they add a 20% markup and a $5 dispensing fee. When that patient goes to Walgreens and says, how much will this cost? The technician's going to tell them $257. Now, the 340B pharmacy, like inside like the clinic, for example, those same tablets only cost 3 cents. So you add the 20% markup and a $5 dispensing fee, and the patient asks, hey, how much will this cost here? The technician's going to say $6.08. It's a pretty significant difference between those two. So this is kind of where the 340B advantage comes in. So a major chain would take a loss selling these medications for anything less than $210. Right? It costs them $210 to even get it in the door. So if they sell it for less than $210, they take a loss. Now, the clinic, on the other hand, with the 340B pharmacy, if they sold it for 90 cents, they'd break even. So a clinic could pick any price between 91 cents and $209.99 and be both profitable and a better value than their competitor. And this is where we kind of get into Q&A with my students when I'm doing this as a lecturer at University of Charleston. What would be the benefits of pricing the medication high, and what would be the benefits of pricing the medication low? And, we'll skip that part. If you price the medication low, you're going to have better patient retention. Patients going to realize, oh, I can get my medications for much, much cheaper here. I'm going to start getting all of my prescriptions here. Pricing high means that, your organization's making more money. You can reinvest that money into additional services or space or anything like that. Like I said, our FQHCs have, substance use disorder clinics. We have dentistry. We have behavioral health. We have imaging. We have a black lung clinic. We have all of these additional services. And some of that is thanks to, how lucrative some of our pharmacy services are. Now, that said, your clinics aren't going to be making the most money off of these cash paying patients. Most of our profits are going to be coming from commercial payers and Part D, because you really can't make profit off of West Virginia Medicaid, because West Virginia Medicaid limits you to about $10.50 per prescription. Cash paying, we don't make much off of those because, we're trying to help people. Our organization, at least, has opted towards the low end, try to keep those costs as low as possible so we can try to get patient retention. So a lot of the profits we're making are from patients with a third-party payer or a Medicare Part D claims. So I'm going to switch gears here a little bit and talk about a few cases that you may have seen over the past couple of years. This here is a obituary for Alec Rayshawn Smith. Alec Rayshawn Smith passed away on June 27th, 2017 due to diabetic ketoacidosis. After he was no longer covered on his parents' insurance, Alec began rationing his insulin due to the high cost. So I faced this when I was a college student. Once I hit 26, my parents' insurance kind of kicked me off, even while I was still in school. So if you look here, Alec was 26 years and 5 weeks old, basically. So as soon as he was no longer covered on his parents' insurance, 5 weeks later, he passed away because he had to ration his insulin. He couldn't afford it. And, that's what happened. Similar case, Shane Patrick Boyle passed away March 18th, 2017 due to complications from diabetic ketoacidosis. So a week after his mother had passed away. When that happened, a few weeks before that happened, he had actually posted a GoFundMe and posted on his personal Twitter to ask for donations for insulin. And at the time of his death, he was $50 short of its goal. A few years back, our local newspaper, the Charleston Gazette-Mail, wrote an article entitled "Insulin Caravan Departs for Canada in Search of Affordable Medication." I'll read the first couple lines here. On Sunday morning, a group of West Virginians will depart from Morgantown en route to Niagara Falls, Canada, but they aren't going to see the sights. Instead, they're going in search of affordable insulin. Roughly 15% of West Virginians suffer from diabetes and depend on insulin to keep them alive, according to the state Department of Health and Human Resources. In the last decade, insulin prices nationally have been rising, making it more difficult for some to access the medication, no matter the health insurance status. According to the Healthcare Cost Institute, an individual with type 1 diabetes paid an average of about $6,000 in 2016 for insulin. Since then, prices have only gone up. Last is this article. It was actually a blog post on GoFundMe entitled "How to Get Insulin When You Can't Afford It: 6 Ideas." This was a fundraising article that was written on GoFundMe, which a lot of people have been using crowdfunding to try to get their medications. So at the time of this presentation, and I've had this slide up for years for my students, and I've never had to change the information because it's still accurate. My cost, when I say mine, I work at a 340B facility. So my cost for no-log vials is 10 cents for a vial, 15 cents for a box. The 70-30, same deal. Our long-acting insulins, the Levemir and the Lantus, same deal. Novolin products, which is what you can kind of get over the counter, like Walmart, for example, 10 cents a vial. If we have a newly diagnosed diabetic patient coming to my facility and they need insulin, they can walk out of there with a box of insulin for $5. And that is what makes these stories so infuriating and heartbreaking, and part of the reason why I try to advocate for 340B services, because of this right here. Another example, this loser you may recognize, Jerad Bailey, was interviewed by the Register Herald several years ago. The byline on this picture was Jerad Bailey, a pharmacist at Kanawha City Health Center in Charleston, West Virginia, holds 2 generic epinephrine doses. Those pens that I have in my hand right there cost 2 cents and are practically identical to EpiPens, which at the time were over $200 for a box of 2 pens. And I'd actually advocated online on Facebook and mentioned to people that, hey, this is, ask your doctor for this, try to go to a clinic like ours. The post went viral, got a lot of groundswell, and I ended up doing interviews with several different news agencies locally, but this one was from the newspaper there. So what can you do? Well, first of all, I want to share with you a few tools. Now, the first of which is going to be the Hersa's Find a Health Center tool. So if you go to findahealthcenter.hersa.gov, it's going to have a search engine function where you can type in your location and a radius, and you can try to find health centers in your area that qualify for like 340B. So for example, I had put in the zip code that I'm local to, and the first result was Sunnyside Health Center, which you can see is operated by Cabin Creek Health Systems. But also I see letters up to M, which is the 13th letter of the alphabet. So it found about 13 different facilities in this small area of Charleston, West Virginia. So if you're trying to figure out like who actually does this locally in your area, good place to start is the Find a Health Center tool. Next place to look is the Hersa Office of Pharmacy Affairs website. So this is 340B opais.hersa.gov. I know it's a mouthful. I think if you just Google Hersa database, it will get you to the correct location. So I'm familiar with this website because this is where I have to do my re-register sites. And on rare occasion, when we register new sites, this is where this happens. So if you use the search function on here, you will be able to search for either covered entities, contract pharmacies, or manufacturers. Now, this is a pretty robust search function that it does offer. The covered entity entries will list what contract pharmacies they're contracted with and vice versa. But it's important to note that in-house pharmacies are not going to be listed because they aren't considered a contract pharmacy. So for example, one of my clinics, which is Kanawha City Health Center, has a pharmacy built in, Kanawha City Health Center Pharmacy. You will not find the pharmacy on the Hersa database because it is still considered part of the clinic. You'll find the clinic, you won't find the pharmacy. So just because, don't let that discourage you if you're not finding pharmacies in there, because the in-house ones are not going to be listed. As far as patient advocacy goes, the most important step in all of this is that that patient has to establish a relationship with the covered entity. And I know this is a hard sell because a lot of patients already have an established PCP that they don't want to leave. I get that. And that's probably going to be one of the biggest hurdles that you'll have to deal with a patient is changing PCP. Amanda, do you have something?
Yeah, so there's a few comments that are here. I'm going to just scroll up and run through them. My type 1 diabetic boyfriend passed away at 29 from complications from his type 1. Insulin affordability is extremely near and dear to my heart. Agents, when your clients say, I switched insulin and have some left, are you able to direct them on where to donate? There's probably JDRF locally where they are happy to take them and to give to people in need. Go ahead.
So as far as like donation goes, I can say that as a pharmacist and a pharmacy, that my location can't take back medication that's already been dispensed for safety reasons. And that's
Mhm.
that's law, that's, you know, ethics, everything like that. There are locations that can do that type of work. I know that I think Health Right locally might have some type of um, service where they can do that. Um, but
I know that
generally,
there's drop-off bins at our local police department in Twinsburg. They have, it's actually a drop-off center. They have a bin there that you can drop off unused medications.
yeah, those are
at the
getting
police
destroyed
department.
though.
Oh, okay,
Yeah. So anything that's dropped off in there is going to get destroyed.
okay.
As far as, you know, the beneficence of sharing drugs that you've already purchased and can't use or haven't been able to use or anything like that. There are agencies that handle that, but nothing centralized. You're not going to see, well, theoretically, you're not going to see a pharmacy offering that service just because that puts a lot of liability
Mhm.
on that pharmacy. So there could be places that could be a service that could eventually be offered or something, because I understand, like, there's a lot of like especially if you're mail order, they just like send you stuff and send you stuff and send you stuff, even though you may have like a stockpile at some point. I know that some patients have like additional medication that hasn't been opened, that's completely safe, that you don't have to worry about.
Yeah.
And there's not like a very good vector to distribute that.
So one of the agents that is on used to work in a pharmacy also, and she says, Amanda, the free clinic I volunteer with doesn't accept insulin because there's no guarantee of prior storage, which I didn't even think about that, but it's a valid point when it comes to that. Scrolling up a little bit, there was a question: is there a dollar limit of the is there a dollar limit of the grant per year for the covered entity?
Not that I'm aware of. There's not really. I know it's weird, like it's weird to think of it as a grant program because we're the ones actually making the clinic is actually the one making the purchase. So I'm not aware of any type of limitations like that, to be honest. And as far as like the grantee stuff on that end, like the medical end, that's where it starts to get a little bit cloudy for me because I've always been on the pharmacy end, but I don't think there's any limitations that I'm aware of.
Okay, and then Chris wants to know, how do we know if the covered entity has an in-house pharmacy? Is it just a matter of calling?
Yes, and I've actually got that like on the next slide.
Okay. So then hold on one second, because I'm going to go through just to catch us up a little bit.
Yeah.
I found the Drug Mart on the 340B HRA or HRSA.gov website. Can a client's PCP get a script filled at 340B? And does the client not need to go to federally qualified health center?
The provider has to be associated with some type of covered entity.
Okay.
So that's the caveat. So like if it's a private practice doctor, that's going to be a bit of a challenge. Now, if it's someone that's working at like a hospital, so a lot of hospitals actually are registered with 340B, particular programs within the pharmacy or within the hospital. I apologize. So some hospitals and some bigger systems like that may actually be 340B eligible as well. So something to look into. But if you're looking at a private practice doctor, it's unlikely. I'll just put it that way.
So next question. If you are referred to a specialist by a covered entity, doesn't the RX still have? Yeah, so we just answered that. Deanna, if I understand, the more 340B is used, its benefits are covered. I'm not reading this right, sorry. So if I understand, the more 340B is used, it benefits the covered entity and the client.
Yes, it benefits the client in that. So the benefits to the client are going to be realized if they are uninsured or underinsured. because depending on their insurance, like even if they're West Virginia Medicaid, regardless of where they go, their prescription is going to be $1 or $2, something like that. They're not going to see a difference. If you are on, Blue Cross Blue Shield, or if you're Aetna, or if you're PEIA or something like that, your prescription prices aren't going to change regardless of which pharmacy you go to. Really, as far as the patient goes, as far as the patient realizes, the big differences they are going to see is when they have to pay out of pocket, or if they're in a situation where they are underinsured, where, if I have one of these big name insurances, but my insulin is still a brand name and my insurance says it's $50, $100 for box. So if I pay cash for it, though, at the 340B facility, it's only $5. So, I could pay $50 and try to meet my deductible and whatever, or I could just try to save $45 a month and pay $5 for it at the clinic. So as far as the patient is concerned, really, that's the only time they're going to see much of a difference. Now, as far as the covered entity, every single claim that comes through is just additional money, right? Like you're doing more business. Some business is, more lucrative than others. So, but the more times a patient comes in, it's just like any pharmacy, the more customers you have come in, the better off you are, right? Because you're going to be making some profit off of each customer that comes in, and that's regardless of whatever pharmacy. So yeah, I mean, it is mutually beneficial. And I think the pharmacies are going to realize that more than the patients, unless they're in that situation where there's coverage gap in their insurance.
Okay, awesome. Thank you.
No problem.
One more question.
Yeah.
So with Part D, wouldn't need this if they reach catastrophic, correct?
Right. So what you're talking about is being outside of the donut hole.
Yeah.
Right. Okay. Yeah. So yeah, once you get to that point, and we do have some Part D patients, depending on what type of Part D coverage they have, they do get some stuff throughout, like what we call our RX discount program. And that just depends on how much stuff is, because we have some patients who sort of live in the donut hole. We have some patients that never see the donut hole, and we have some patients that are in catastrophic in March, right? So like we've got a little bit of everything. So depending on what their coverage is like, it could still be beneficial to them to have some type of like 340B coverage.
Jared, can I jump in for a
Sure
second?
thing. Yeah.
I mean, because this is where I was telling the group, I send probably hundreds of patients to you guys a year that are on Medicare. And when they use the 340B, it allows them, they can skip that, the deductible period, the donut hole. It allows them to where they can skip that. So, I mean, I have tons of patients that I send out there to use, even though they have good insurance, they don't fall for LIS or any type of help. And so it can save them thousands of dollars a year.
Awesome.
So yeah, Tabitha brings up a good point. It's sort of case by case. It's some patients are really underutilizers of their insurance and may not need, like 340B coverage or anything like that. Some patients, it might be cost prohibitive. Like it might be the difference between a $10 copayment and a $5 copayment. And if you're on a fixed income, extra $5 every couple of weeks could be beneficial. It's an extra meal or something like that. Or, anything catastrophic happens around the house, you have to fix up or anything. So it really is case by case. The only real like broad strokes I can say is that for certain, if a patient is uninsured or underinsured, the 340B program can be a lifesaver. That's probably the biggest broad stroke I can make, and not have to put like an asterisk next to it and say or but or anything like that. Anything else, Amanda?
Yeah, I'll read them off to you. If
Oh,
that's
sure.
Okay.
Yeah.
Deanna said, the reason I asked is I've learned the East Liverpool Hospital Clinic is a covered entity and it requires a visit, and they use an in-house pharmacy. I just didn't want to overwhelm them if this was a limited grant benefit or not beneficial.
No,
Okay.
as far as I know, I don't think there's any limitation. And honestly, so long as it meets the definition for, patient eligibility, they're probably going to love to have the business.
Okay. And then one final question. Do you call the covered entity to see who their contract pharmacy is, or is there another way to know?
So yes to either of those. So I'm going to go back here. If you search on the Hersa OPA database, so we had this website right here at the bottom, 340B, Office of Pharmacy Affairs, IS, I forget what the IS is, sorry, but the OPA IS. If you go here and you use the search function, it's going to ask you about covered entities, contract pharmacies, and manufacturers. Now, when you look up the covered entity, it's actually going to also list any contract pharmacies that are associated with that covered entity. And I'm going to go into a little bit more about this. I've only got about a half dozen slides left, so we can hit questions there. So back to the
You've
patient.
got another hour, so take your time with what you've got. We're good.
Well, I want to give plenty of time for question and answer, but I just want to let you know that the slides are almost done, and then we can kind of, just mitigate interruptions and stuff with it.
Throw a party, have a good time.
Yeah,
light
heck
up
yeah.
some shots.
Heck yeah.
Let's
do it.
Yeah.
Go for it. So the patient advocacy, like I said, the most important thing and the hardest sell is going to be establishing a patient care relationship with the covered entity. And that the covered entity either needs to have their own in-house pharmacy or utilize contract pharmacies. Because if they don't have pharmacy services, then it doesn't really matter if they're a covered entity, because the patient's not really going to be able to benefit from cheaper medications. Now, I will say that agreements between covered entities and contract pharmacies can vary wildly. And if you have an uninsured or underinsured patient, these agreements may not benefit the patient at all. Some of the agreements I've seen between covered entities and contract pharmacies look at a just brand name medications for patients that are just insured, because a lot of these contract pharmacies, like a lot of the big boxes, your Walgreens, your Walmart, your Kroger, really they're only looking to go into this partnership if they can make profit off of it. So they don't necessarily have patient beneficence in mind when they are hoping to become contract pharmacies. So it's entirely possible that like the patients that could benefit the most, it might not even benefit them. Now, smaller pharmacies or mom and pop pharmacies might be a little bit different. So just because there is a contract pharmacy associated, it might not benefit your patient. So this was alluded to a little bit earlier, finding clinics and in-house pharmacies. It's going to take detective work. So you can find facilities in your area that are registered as 340B facilities. Call them. Ask them if they have a pharmacy, ask what other services they offer. You can also check search engines or social media for pharmacy entries. Like I said, even though our clinics have pharmacies, you may not see them on the Hersa database, but we appear on Facebook, we appear in Google. And I've called health centers outside of West Virginia before. So I've met people online, I've talked to them about affordable medications, and I've actually advocated for them. I've called clinics in Texas, I've called clinics in Maryland, and just introduce myself, say, hey, I'm Jerad, I work for Cabin Creek Health Systems in Charleston, West Virginia. We offer similar services to you, and I'm calling on behalf of a mutual patient, because at that point I'm consulting, so why not? They're a mutual patient. And I wanted to see if you all had a pharmacy, or if there's anyone I could speak to you about, your 340B program, anything like that. And usually whoever's on your PSR is going to have some of that information. And I've always had good luck. They've been pretty helpful. Like asking if they've got a pharmacy or not is a pretty quick yes or no. Like usually whoever's on the phone is going to know the answer to that pretty quickly. I will say that about 2/3 locally, I'm talking about West Virginia here, about 2/3 of local FQHCs have an in-house pharmacy, and about 2/3 utilize contract pharmacies. So if you look at the little Venn diagram here, it's about 1/3, 1/3, 1/3. So about 1/3 have both, about 1/3 only use contract pharmacies, about 1/3 use in-house pharmacies. So if that's anything like your local area, you might have a good shot at finding one within your first couple of calls. Last major thing I want to cover right now is that the 340B program is kind of under attack right now. So as you imagine, anything in which, there is the movement of money, people want a piece of that pie, and then people take offense if they're not getting a big enough piece of that pie. And right now, there are some pharmacy benefits managers, and there are some contract pharmacies and TPAs that have been being able to get a cut of this pie at the expense of health centers and covered entities. And the manufacturers are kind of hitting back at this, not by really targeting people that are sort of abusing these partnerships, but by rather just, trying to take their ball and go home. And part of the agreement was that these manufacturers were told that they have to, offer these drugs at a certain price if they want to play ball with Medicare, Medicaid, whatever. What the manufacturers have found is that they've been sort of inching away from that and trying to be able to charge higher prices and not offer these benefits or certain drugs to certain facilities, and that Hersa hasn't really slapped them on the wrist over it. So it's just kind of continuing to happen. Now, the National Association of Community Health Centers, or NACHC, has been trying to advocate and try to, make it clear that this is happening. But 340B is something we'd like to see stick around for a good long while. And even though it sounds beneficial for all parties involved, not everyone thinks so. So I just want to show this off to you and let you know that even people will find a reason to complain about anything, no matter how nice it is. Here's a quick look at sources here. And last, we're kind of already talking about questions. But yeah, I guess I'll open the floor up to any questions that anyone has. I'll leave this on my contact information here just in case. But yeah, I'll at this point just open the floor up to any questions anyone may have.
Jerad, I don't know if you'll know the answer to this as well. But one of the questions everyone seems to ask a lot is when they call the doctors or they call the pharmacies, no one really seems to be open to, we don't know what the 340B is, or we don't know what that, do you know why that is?
As in like outside facilities, like just, do you have a particular like example or use case here, or?
Yeah, like if they call the clinics or the federally qualified places, or even doctors, in my experience, like I've been going to a federally qualified health center for 15 years, and they've never mentioned to me that this is an option, even though I know it's an option. Why is that?
It's more of it's an operational thing, I believe. So even with my facility, and I would like to think that we're pretty well versed on 340B, or at least I've tried my best to make sure people are well versed. Other than, some of our C-suite, so like our CEO, COO, CFO, and some of the other stakeholders in the pharmacy, I would say maybe 10 to 20% of our staff, their ears might perk up if you say 340B. And the vast majority of those know enough to say, you should ask Jerad about that, because I've heard of it, but I don't know enough about it to be able to answer your question. That I've got a few other people that know a lot of the nuances too. I'm not going to say that I'm the only person there. That's unfair to my staff. They do pretty well with it, but honestly, the most people aren't going to know. I would say, I don't know how many of our staff know that we are a federally qualified health center. They know that we're a health center. I don't know how many of them know that, we're federally qualified, or how our funding gets there, or anything like that. So right. It's really operational. Like, it's not something we really advertise. I would say the vast majority of our staff know that our pharmacy gets drugs really cheap, but they
Mhm.
don't associate that with 340B, right?
Yeah.
So it's I think it's just the way this stuff is sort of codified. Like, all this
Just
stuff I've
wanna-
been able to codify is like, oh, 340B, and it's so I think it's operational and educational.
I just wanted to stress that because this is now the third training probably we've done on this. And that's something people keep coming across, is that they feel like um, health centers or doctors don't want people to know about this. And so they purposely keep quiet, but it's not, it's just they're not versed in what it is.
Right. I mean, I don't think it's anything malicious at all. I think people
Mhm.
just don't know what it is. I don't think it's like a big secret or anything like
Right.
that. And our providers know at this point because, we have the in-house pharmacies, which helps because having the in-house pharmacy means that our providers are more likely to come in and ask us questions, which we absolutely love. And a common question is, do you have this in stock? How much would it cost for my patient? And when we tell them, yeah, this Pro Air inhaler, $5.
Right.
Wow, like, you get a strong reaction. They remember, like, hey, some of the stuff I can get cheaper here, and then they start advocating to their patients as well. So
Mhm.
some of it comes from like personal experiences too. So I think a lot of that might be like, oh yeah, I use this pharmacy and I got this for this much. Like it. So I think a lot of it is always like these personal experiences that people have had, either trying to help a patient or being that patient themselves and realizing that these medications are much cheaper.
Mhm.
You may, if you speak with like the pharmacy staff directly, that's going to be most likely the people that know about 340B because they have to follow the rules. Nobody else has any rules to follow. The pharmacy, if you've got an in-house pharmacy, they have all these rules they have to follow to make sure that there's an eligible patient. So I pretty much assure you most everyone in there knows what 340B is.
Yeah.
But yeah, I don't think it's malicious at all. Like, and we're not trying to keep it a big secret or anything. I think it's a lot of it's just sort of education.
Yeah, I agree. I mean, because that's one thing. And then I'm getting ready to go in to answer some of these questions or to call them out to you. But I I want to emphasize it really is like a treasure hunt. You may have to call back several times to talk to someone that really understands what the program is, who to talk to. But if you can find out if it's an in-house pharmacy, the easiest way is just to call the in-house pharmacy. If it's a contract pharmacy, sometimes that's a little bit harder because you have to find someone that you can talk to that will actually know what the program is and then tell you who the pharmacy is. That's my experience. All right, Jerad. So a couple of people asked if we could put the resource pages back. I don't know if you want to put that back, or I can just also send out the slides.
I'm okay with you sending out the slides if that's okay. That way everyone will have a copy. They'll have so I know that some of the stuff like the little timelines, just to be able to follow along with, where Medicaid and contract pharmacies and stuff fit in. But I am okay with you so putting that in there.
So
Okay.
I'll go ahead and I'll route the slides out after we get done, along with, once I get the video of this uploaded onto YouTube, then I will go ahead and I'll share that link. Also, I'll copy you, Jerad, on it so that way you have it.
Okay.
And then everybody can use that for reference as well. So, which is always a good thing.
Yes. Another question. I just chatted with Ryan White Center in Dallas and got slapped down. Do you participate and what's the cost? The response was yes, but the patient will need to make an appointment. I think that's a common response that.
Yeah, and I mean that goes into patient eligibility too, is that
Mhm.
the covered entity, which in this case is the Ryan White Clinic, has to establish a relationship with the patient. They have to have a visit with the patient. It's not good enough that, they've promised to make a visit and now we're refilling their medications, because the definition says that, giving out drugs does not constitute a relationship. So I am not shocked that that was their response, because that's part of their criteria to make sure they maintain the integrity of their program.
I know me, when I'm calling to find about a patient, I already know that's what they're going to ask. And so I just say, hey, I have a patient of your clinic and this is the medication that they're on. Can you tell me if they picked it up at your pharmacy, what the cost would be? And then they're really open with telling you. But if you just say, I'm going to send someone, then you get shut down really fast. Like, we have to be a patient, you have to fill out paperwork, you have to do that. So I just say they're already a patient.
Yeah. Don't be shocked if they try to follow up with you and see what their name and date of birth and stuff is. So don't like try to slip that in there. Like, a lot of places will still like look for, that patient in their system.
Yeah, absolutely. This is not a question, but it was something someone asked me earlier. So for the federally qualified health centers, you don't have to be income-based to get in. So, right, but for some of these things, you do have to be income-based. So it's not so much that the 340B drug is based on your income, it's that the entity might be based on income, right?
Sorry, I was putting up that the sources
Okay.
page here. I'm not sure this was exactly what people were hoping for, so I can flip to additional resources
That
here
was
in a
it.
moment. But could you repeat that question for me again? I'm so sorry.
No, you're fine. So a couple people were asking, they said that they were having difficulty because they were saying it was income based. But my understanding is that the covered entity might be income based, but not the 340B.
So Hersa, our facility actually had like a Hersa on-site visit recently, and we are encouraged to have like sliding fees that are income based. So like our RX discount program, in order to apply for the RX discount program, there is an application and there is a you do have to bring in proof of income. And this is mainly because a lot of third-party payers and insurances require us to do this because insurances, if they see that we are offering a discounted price to every single patient that comes in the door, that is what they want to reimburse us based off of. So if you remember the case study slides where I said that the insurance might reimburse us for like $9 a pill for rosuvastatin, if we are giving everybody rosuvastatin for 3 cents a pill, the insurance will say, hey, we want to reimburse you for 3 cents a pill, in which case we don't get any profits at all. So what we have to do to get around that is actually create a discount program that has some hoops. Not just anyone can come in here. You have to fill out an application. You have to jump through some hoops, but once you do, you can get that medication for a cheap price. Now, on our medical side, we have a sliding fee. So like your medical services will have different co-payments depending on what your financial level is. Our pharmacy does not, and that's actually something that Hersa wants us to address. They actually want us to have different pricing plans for our pharmacy, and that's something we'll have to evaluate in the near future. But as of right now, today, we don't have anything like that. So it does not shock me that some pharmacies do have sort of like a income test or something. A lot of that has to do with the way insurance programs have sort of looked at the 340B program. And again, that's, we were talking about, there's the pie and people wanting a piece of it. And this is the insurance way of trying to recuperate money, is by making sure we're, not offering the cheap price to everyone except their patients.
Got it.
So you could run into that. That's absolutely a possibility.
Someone wants to know if there are any brochures available about 340B.
Nothing that I'm aware of.
Yeah.
Hersa, hrsa.gov is probably the best government resource on 340B. Apexus, APEXUS, is who manages a lot of the education parts of 340B. So if you want to read more about 340B, go to Hersa. If you want to learn more about 340B, I would recommend Apexis, because their materials usually geared a bit more towards like learning instead of just regurgitating facts at you and law and all that stuff. So as far as like brochures and stuff, not really. I would say you would have to lean on the individual programs. So my facilities, we have a contract with a media group who makes brochures and stuff and talks about like, hey, we also have pharmacy with like cheaper prices and stuff like that. So I don't think you're going to see anything on like a grand scale. It's probably going to be more at the individual sites may have something like that for your patients.
Did you have anything, Amanda?
Nope, I'm good.
I think, okay, it looks like there's people are thanking you. And then they want to know, do you have any language that you suggest people use when they call into hospitals and the federally qualified health centers to find out what's covered?
So that's interesting, because I've had to do that very thing. And so I have, when I've called outside health centers, usually I try to introduce myself first, let them know, hey, I work in Charleston, West Virginia. I've got a patient in your area that might be interested in using your facility. Because the Hersa website is going to tell you if it's an FQHC or not, thankfully. So you don't have to rely on the person on the other end of the phone knowing if it's an FQHC. You already know that it's an FQHC. The other thing that the Hersa website is going to show you is the primary contact. So let me see if I can, might be switching what I'm sharing here on my screen here. Give me 1 second. Share screen. I want to share that. Can you see my browser?
Yes.
Cool. So I'm going to show you this website here real quick. This might help answer. This will be a part of the answer here. So I'm going to use search. I'm going to search for covered entities, and I'm going to look for mine. So up here in keyword, I'm going to type in Cabin Creek. Those are usually the only ones there. Every entity is assigned a 340B ID number. So if you happen to know that, it's unlikely you can put that in there. The entity name, you can put like the Cabin Creek in here if you want to, or if you've heard that this particular hospital has one. You can type in city, state, zip. It'll pull up all that information. I'm just going to search for Cabin Creek here. And here's all the Cabin Creek sites that are associated with 340B. So each particular brick and mortar location has its own entry. So we got Cabin Creek, Riverside, Sissonville, Clendenin, Kanawha City, Pioneer. These are school-based health. This is inside the Kanawha Charleston Health Department. FP is for family planning. So even, family planning is one of those types of covered entities as well. So even though they're located in the same location, it's not our community health stuff, it's our family planning stuff. So look for like CH. This entity type is going to tell you like what type of entity it is. So I'm just going to look at this what they call the parent. So it's going to have the 0 at the end, not A, B, C, D, E, F, G, H. No, it's going to be the 0. Okay. So if we go here, some cool information. First of all, we've got our address, billing address, all this stuff right here. Good info. Each site on the Hersa database has to have an authorizing official and a primary contact. Now, the authorizing official is usually going to be like your CEO or someone high level in the organization. That's the one saying, yes, I want to stay in this program. No, I don't want to stay in this program. This primary contact, take a look at who this is for my organization. That's me. There's my contact information right there. So even though the authorizing official is the one that's probably doing the decisions, the one that's handling maintenance of this website, of the address, of the billing address, anything like our contract pharmacies, which these are dated. So these are terminated. So here's some contract pharmacies that we used to have. You can see that those were terminated last year. But you can get all this information on this website. And if you have questions, and if you're looking for like the person to talk to, this primary contact is going to be a good place to start. So if you call a clinic and you're trying to get info and it doesn't seem like the person has any info or knows really who to speak with, you can say, hey, is there any way I can get in touch with Jerad Bailey? Because depending on what their position is, they may know who Jerad Bailey is. I've been with my organization for 10.5 years. I think a lot of the people know who Jerad Bailey is in this particular case. So it's a good place to start. Failing that, or like, oh, Jerad Bailey doesn't work with that organization anymore. Well, let's step up to Craig Robinson, because what this tells me is that this info needs to change within the next year, because Hersa requires us to recertify every single year, which means at some point within the last year, this information was accurate. Okay. So this is a good way to try to figure out who you need to speak with, because hopefully this is the person that is going to know the absolute most about that 340B program at that particular facility. So yeah, I would start with the PSR, whoever you're on the phone with first, like, hey, do you have in-house pharmacy? Do you know anything about the 340B program here? And failing that, it's like, is there any way I can get in contact with Jerad Bailey, or can you pass my information along to this person? I would say that would kind of be the route to go, and hopefully that gets your foot in the door.
Okay, so did somebody answer the question, how does this compare to something like CleverRx?
I am not sure if I know what CleverRx is.
So CleverRx is the same thing, only different, like GoodRx is. It's just another one of the discount cards. Can you talk a little bit about discount cards versus 340B?
Yeah, sure. Most of my experience is with GoodRx, and I can tell you pretty much across the board, 340B prices are going to be better than GoodRx, to the point where we actually don't even take GoodRx cards at our pharmacies, and we can compare those costs and show them, hey, 340B is better. As a pharmacy, GoodRx is very pro-patient and anti-pharmacy, because GoodRx will typically send you bills for the benefit of using their service. So you'll get some money today, and then you'll get billed for it later. So your reimbursement with GoodRx and potentially CleverRx, I'm not sure what their business model looks like, but a lot of mom and pop stores won't use GoodRx because it's not good for business. Now, larger chains who want to try to have where their pharmacy is a loss leader. So like Walmart, for example, Walmart's pharmacy doesn't really net them a lot of money as a business. What it does net them is that patients that are going to be in their store for 20 to 30 minutes. So that's where kind of how they realize the benefit. Like Walmart was the originator of the $5 list or the $4 list. And that, yes, it helped patients, but that wasn't their primary goal. Their primary goal is to try to get more people into the building, because they didn't make money off of $4 drugs. They made money off of you going and buying some groceries while you waited for your $4 drugs. So that was kind of the business model there. So Rachel asked, even though you have an in-house pharmacy, you can have contracted pharmacies? Absolutely, yes. And what that does is it helps you cast a wider net. So like I said earlier, you can't really control where your patients go as far as a pharmacy goes. And if you have a patient that's on Blue Cross Blue Shield, I'm just throwing that out there because it's the one that comes to mind, and their copay is the same regardless of where they go, and there's no real benefit to go one place or the other, we can't require them to go to our pharmacies. But if they happen to go to Walgreens, and we can establish a contract pharmacy relationship with that Walgreens, our clinics could potentially recover some of that rebate from having that Walgreens as a contract pharmacy. So as a covered entity, you're basically broadening your net and able to capture more rebates and more revenue, basically. So that is absolutely something you can do. And again, I would say about 1/3 of the FQHCs in the state are using that model.
Hey, Jared, one other question that people ask a lot is they just assume there's one list that every 340B charges for each medication. Can you explain why it may be $5 at one 340B and 100 at a different one?
Yeah, absolutely. And that kind of goes back to one of the slides that I had a little bit earlier where we were talking about, as a pharmacy, like it was the Crestor example. Let me pull up the slideshow again here real quick. And then let me find that.
By the way, tons of people are thanking you in the comments. I'm amazing.
Glad to be able to help here. So can you see the slide view here? Okay. So back to this, like on this fourth bullet here, a clinic's in-house pharmacy could pick any price between 91 cents and $209.99 and be both profitable and a better value than their competitor. So really it's up to the clinic. So we are paying the same amount for that medication. It's just a matter of how much do we want to charge, and the prerogative's ours. So it's not that the government is saying that we're price gouging or anything like that. If we did end up saying like we want it to be $100, because again, the primary goal of the 340B program is to stretch scarce federal resources as far as possible, reaching more eligible patients, providing more comprehensive services. And it is much easier for a clinic to provide more comprehensive services if they are making $100 profit on a drug rather than 50 cents profit off of a drug. And especially if it's still the best deal in town, you're still undercutting your next competitor by 50%. And, so now our organization, again, and there's no real right or wrong answer to this. It's kind of an ethics question, right? Like, if you can provide this drug for 50 cents, why aren't you providing this drug for 50 cents? Well, it's hard to keep the doors open if you're not bringing in some amount of profit. Like, I would like to still be able to provide this benefit to you, but I have to be able to fund it, right? And that's what they've decided to do. And I think a lot of our grant funding has sort of nudged us that direction too. So the pricing is absolutely the prerogative of the facility. It's just, there's different goals, and that might be a case for like, they may have a sliding fee that makes it a bit cheaper for certain income levels, but yeah, like as far as pricing goes, like we're all purchasing that Crestor for the same price. It's just a matter of, how do you want to upcharge it?
One more question. I think we might be done, but I just wanted you to address this because I think people have an idea that these are like clinics, like they're anywhere that you can get these medications, like it's for only low income people. They're not nice facilities. And that's so incorrect. And I just wanted to give you a chance to answer that.
No, not at all. So I'll see if I can let me see if I can pull up our website here. So our newest clinic was actually opened in 2017 in Sissonville. It doesn't have a good slideshow of pictures or anything there. So yeah, it's not, we've got facilities everywhere. We've got one of our facilities, our oldest facility, it was opened in the early 90s. Okay. It's been around a while. Yes, it's been, dated. I get it. One of our buildings is in a beautiful old middle school that's about 100 years old, and we're like in the center floor of it with this gorgeous view of the Elk River. One of our facilities was built brand new with modern architecture and everything, lots of natural sunlight coming in. This is not like it's not like decrepit buildings or anything like that. And it's see the thing, you can get that anywhere, right? Like it's not just like any type of facility, any type of hospital, any type of doctor office. Like it's kind of unfair to say that all clinics are nasty, because like that's not the case. That's just one extreme of what it could be. Not all of our facilities are, like architectural masterpieces or anything like that. Like so, but yeah, I mean, it's just going to be, some places have had to meet the patients where they are, right? Like it's just a fact of the matter. Like some places started off as like a modular, someplace in a poor town, and they've been providing services for years and years, and it's exactly what that town needs, right? So I'm from Charleston. I'm originally from Bluefield, and you don't have to drive far from the capital of West Virginia to get into some extremely rural areas. It doesn't take long at all. And I know I think we've got some stakeholders here from like Ohio. I'm sure that's the case there. Regardless of where you are, it's just kind of unfair, but like it's, everything's gonna be like that. No, Marilyn Walker, you bring up a good point, and this comes up a lot. Is this only for human drugs? So yeah, because you have to go back to the patient definition, which is, does the covered entity regularly provide veterinary services? And can you get a covered entity that does provide veterinary services? So I get it. I understand. We've had that question quite a bit, and it's actually something that we've had to investigate too, because like, can we do this for pets? And technically we can't. But no, that it sounds silly, but it's honestly come up, and I get it. I've got a coworker of mine who has to give her dog, like a little Chihuahua, like Lasix 2.5. Like she's got to cut and it's, the vet charges like $80 for it. And like, we could just take a 10 and quarter it, and it would be like nothing. Like we throw Lasix 10s away when they drop on the floor. Like what's, why are they charging $80 for a quarter of one? So I get it, but regretfully, the government would say that your puppy or your kitty does not meet the patient eligibility requirements.
Amanda, you have anything you want to finish off with? Other than Jerad, again, thank you so much for doing this.
No problem. Glad to help.
Yeah, I appreciate it. It's very, very informative, and it's one of those that you really don't get a whole lot of information about it. So I appreciate you taking the time out of your busy day. I know I'm off, so just from pain meds and everything else from the last week. But I appreciate the time, and I will get everybody out the slide deck probably later on this afternoon, and then upload the YouTube, so that if you needed to rewatch, or I know that we had a couple of people that needed to jump off for appointments and things like that, so that they can come back in and view it. That's fantastic. So yeah, Pam, you will get a copy of the slide deck. Other than that, thank you everybody for going ahead and attending, and y'all know how to find me if you need me. I'm happy to help with anything, but otherwise, have a great afternoon, everybody, and I'm sure I will talk with y'all soon. So thank you.
Thanks, Jerad.
No problem. You all take care.
Bye.
Okay. Bye.